David Hausman, and you're tuned to Vital Signs, a community service program that discusses medical topics in the news, sponsored by Phelps Memorial Hospital. With me today, I have Dr. Ken Powers, a urogynecologist specializing in female incontinence and in pelvic prolapse problems. Dr. Powers, who's an associate professor of OBGYN at the Einstein School of Medicine, is also the director of urogynecology at Montefiore Medical Center. Dr. Powers, who's now a consulting urogynecologist at Phelps Memorial Hospital, is a graduate of Columbia and trained at NYU and Einstein. Dr. Powers, welcome. Dr. Powers, what is a urogynecologist?
A urogynecologist is a gynecologist with training after residency and treatment of pelvic floor problems, incontinence, pelvic prolapse, and other problems.
Now, obviously, we're talking about women here. Pelvic floor I can't even say that. Pelvic floor problems consist generally of what?
Commonly thought of as either incontinence, urinary incontinence, or pelvic prolapse.
And prolapse, what does that consist of?
Typically, the pelvic structures, the uterus, the bladder, the rectum will prolapse into the vagina and begin to protrude from the vaginal opening.
So there are organs or things that are essentially coming out where that really don't belong there.
Yes.
And that's how most of the women are presenting. They've got something, a bump or a lump, or something that makes them uncomfortable, I would assume.
Most patients complain of something of something protruding. Some patients just feel pressure and discomfort in the vagina but don't actually feel a protrusion.
Very common problem?
It's very common as patients, especially as patients age after having children. Up to 20% of patients would have some form of prolapse without incontinence. Up to 40 to 50% of patients would have some sort of pelvic floor problem, whether it's incontinence, prolapse, or both.
So the female pelvic organs, uterus and the cervix, and the rectum and the bladder are basically the pelvic organs that can protrude one at a time or all at once.
Each person's different. The structures that hold up the vagina, that provide support to the pelvic organs, can be damaged in different ways. So not everybody has all the organs prolapsing. Some just have the uterus or just the bladder.
Now, is this something that occurs, you notice that it occurs more often with aging, related to what events? I assume it's the support structures themselves. I mean, there's no bones down there. If you take a pelvic bone, it's just a kind of big opening. Obviously, it's got to pass a baby's head through it, so it's got to be fairly large. Those muscles are weakened? Is it muscles and tendons that support things?
It's a combination of the muscles being more weakened as you have children and get older, and the structures that physically attach the vagina in the pelvis, can be torn or damaged in childbirth. So it's a combination of factors.
I'd have to guess it's also that obesity also plays a role.
There's several factors besides childbirth injuries. Patients who are overweight, who have bad asthma, COPD, who might do a lot of lifting at work.
Bearing down, yeah.
Connective tissue problems where the tissue is damaged to begin with. Some patients with neurologic problems. So patients who don't have children can have pelvic prolapse because of other medical issues.
Now, what are the classic ways of dealing with that kind of prolapse problem?
I think in general, the first thing is to understand what's prolapsed. So to do a comprehensive examination and a history to understand if there's any other problems. In dealing with prolapse, generally you're looking at complicating factors. If the patient's obstructed from the prolapse, that they can't empty their urine, do they have a growth in the ovaries or something else wrong with the uterus. In patients who have an uncomplicated prolapse problem, it's mostly focused on what the patients want to do. Some patients try to avoid surgery and they can try different techniques of pelvic floor muscle exercising. There's support devices called pessaries. And some patients prefer not to try to maintain those non-surgical methods and choose to have a surgical procedure done to repair the prolapse.
And surgery can present as either a supportive procedure where you can bring things back up to where they belong, fix them in place, or remove them.
Typically there are ways to be conservative in terms of uterine preservation. Depends mostly on what the prolapse entails. As the prolapse gets more extensive, it's more common to undergo a hysterectomy with a repair. In younger, healthier, vigorous or active patients, an abdominal incision can make the repair stronger. In some instances, vaginal surgery is preferred. So depending on the patient's whole medical picture, you might have a surgical procedure done either way, just depends. The anti-incontinence procedures can be done with an incision, or more commonly through the vaginal area.
How successful are these procedures? These either dealing with the prolapse, a larger operation obviously, or just supporting the urethra with a sling. How many people are going to have the kind of result where they're going to be able to go back to a normal lifestyle?
Well, that's a good question, because I think a lot of people avoid talking about the topic with the doctor because they're worried about how effective treatments are. So to me, the most important thing to realize is most patients I see have both types of incontinence. They have the urge incontinence, they have the stress incontinence. So for that patient, a surgical procedure alone, the urge incontinence may continue. So medicine after surgery helps.
You need the evaluation to make sure that you've covered all bases, that you've treated all the components of the incontinence.
Right, and that you take a comprehensive approach. Surgery for stress incontinence over time is 85% effective. Some patients...
Well, that's pretty good, 85%.
Right, and that's cured and improved. Some patients aren't satisfied, so maybe 8% of patients see no improvement. But the thing I see is patients have the urge incontinence, don't feel that part got better, and are disappointed with surgical results. So I always take the comprehensive approach of treating both conditions concurrently, and if you have surgery, realizing you may need medicine in addition, so that you feel satisfied, because the whole goal of treatment is to improve your lifestyle. The surgery is one of the treatments. It's not the only treatment, and though it's highly effective, it's meant for certain things, and so it's important to take that comprehensive approach to treatment.
So to summarize what we've discussed today, number one, incontinence is never normal, at least after the age of 3. That if a person has enough leakage or enough voiding abnormalities, frequency, urgency, and incontinence, such that it's affecting their lifestyle, they should certainly be seeing somebody about it. That there's various causes, that's not one cause or one event, that you can have an irritation, and in fact you have combinations, an irritated bladder and anatomic problems. But that these problems are eminently treatable, easy to evaluate, or relatively easy, especially if you know what you're doing. So you can evaluate it, you can figure out where the problem is, and you have lots of options for treatment, and the treatment's pretty effective.
Right, and I think that's the main thing, is don't be scared to talk to your doctor. There's many treatments. Many of them don't involve surgery. The treatments are highly effective. And with proper care, most patients improve and don't need to tolerate their incontinence symptoms.
And I think we have to leave it there. So the take-home message is, if you're having voiding difficulties, especially if it's affecting your lifestyle, first mention it to your family doctor. Go through the basic workup that your doctor is going to institute. But if you're still uncomfortable and your problem hasn't been resolved, then it's time to go see somebody who deals with that specifically. Dr. Powers, whose number hopefully is somewhere down here at this time. You can contact him either through his office or through Phelps. And please feel free to discuss this with your personal gynecologist and with your doctor. And thank you for watching. Hope to see you next time.